Good afternoon. I'm Catherine Santoro, Director of Programming at the National Institute for Healthcare Management Foundation. On behalf of NIHCM, thank you for joining us today for this important discussion on ways to support access to mental health care. Nearly 1 in 5 Americans live with mental illness, and despite growing awareness and understanding of mental health, it is still difficult for many to get the care they need. Over half of adults with a mental illness do not receive treatment. Many Americans live in areas with a shortage of mental health professionals and experience a variety of barriers to mental health services. Additionally, the COVID-19 pandemic has exacerbated and contributed to existing mental health challenges and increased the demand for services. Barriers to receiving mental health care range from affordability and availability challenges to the persisting stigma associated with mental illness. May is Mental Health Awareness Month and a time to address the impact that mental health has on the well-being of all Americans, and a time to collectively work together to address barriers to improve access to mental health services for those who need them. In supporting mental health and access to services, we hope that anyone affected by mental illness can get appropriate support and care. Today, we will hear from a prestigious panel of experts to learn more about mental health and strategies to improve access to care, including culturally responsive support and crisis services. Before we hear from them, I want to thank NIHCM's President and CEO, Nancy Chalkley, and the NIHCM team who helped to convene today's event. You can find biographical information for our speakers, along with today's agenda and copies of their slides on our website. We invite you to join the conversation on Twitter using the hashtag #MentalHealthSolutions. I am now pleased to introduce our first speaker, Dr. Ken Duckworth. Dr. Duckworth serves as the Chief Medical Officer with the National Alliance on Mental Illness. Dr. Duckworth is a leading mental health expert, board certified in adult and child adolescent psychiatry, and has extensive experience in both the public and private sectors. We're so honored to have him with us today to share NAMI's recent work on mental health. Dr. Duckworth?
Thank you, Catherine. I'll be speaking for about 10 minutes or so. Make sure we have time for conversation. We have 2 other terrific speakers as well. So reduce suffering on your part. I only have 2 slides. So let's take the first slide, please. So as Catherine mentioned, the pandemic has been a watershed moment in mental health in many ways. And one of the biggest is many more people reported having the experience of a mental health condition. And in this, I say, best of its kind survey to date, the CDC indicated in an online survey of June 2020, so that's 3 or 4 months into this, reported out in August 2020, about as close as a real-time biopsy as you're going to find. Many people, 41%, reported a true mental health condition. So they used the PHQ-9, the GAD-7, a trauma scale that's validated. And if you take a look at this, anxiety and depression, 31%, trauma, 26%, increased substance use, 13.3%. Suicidal ideation increased to a pretty high number, over 10%, and it was higher in young people. They didn't do age, 10 to 17. They started at 18. They wanted to do adults. Hispanics were higher. Black respondents were higher. Unpaid caregivers for adults were higher. Much more suicidal ideation. And essential workers. So this is a transformation. In my way of thinking about this is that mental health went from a they problem to a we problem. I was impressed that I probably did 8 times as many media conversations in 2020 as in 2019. People wanted to talk about recovery, telehealth, connecting with others, how to find a therapist because of the supply-demand mismatch. And I feel like it was a transformational moment. And if there is a silver lining to the mental health aspects of the pandemic, it is that so many people experienced it in themselves or in their family members, right? So with 41%, if you have 5 people in your life, it's now statistically unlikely that none of them are involved in having a mental health condition that they're experiencing. Let's go to the next and final slide, Catherine. So I took advantage of this opportunity to write Nami's first book, and I made a very deliberate, intentional set of decisions about the book. The National Alliance on Mental Illness, which is your largest grassroots organization in America for people with mental health conditions and those who love them, has never had a book. And I always thought it would be a good idea. I want to emphasize this book, which is up for sale on Amazon. All proceeds go to Nami. This is a love gift on my part. This is something I just wanted to do for Nami. Book's going to come out in September, and I want to tell you a little bit about it because this is one of the things that Nami is doing. Nami also led the 988 crisis phone call movement. So, 988 will hopefully become the 911 of mental health crisis for the National Suicide Crisis Prevention Suicide Prevention Lifeline. It doesn't really create services. That's another advocacy challenge, but I would say that's big recent NAMI activity. The book, I interviewed 130 people. I interviewed real people who used their names. I did not use composite people or fake people, as many books do. The whole idea of this is to reduce the shame and discrimination. Those wolves that you hear in the background are 2 dogs, one a nearby neighbor's dogs, and they've decided only during my talk to get quite involved in battling out each other. So don't worry, nothing terrible is happening. It's just 2 dogs. This is the joy of home work in the pandemic. 130 people, about 80 of them have first-person lived experience, about 50 of them are family members. And I asked them, what worked for you? What made a difference for you? What helped you communicate in your family? How did you manage some of the tensions in our field? And then I also did something that I hadn't seen in a book, but I always wanted, which was to have America's experts answering the most common and important questions that I get as the NAMI Chief Medical Officer. And so this is both first-person questions and family questions. So the first-person questions would include, why should I participate in research? That's answered by Josh Gordon. I get that I have bipolar disorder. Do I really have to take these meds forever? That's by Dr. Andy Nierenberg, the Mass General Hospital. How do I think about interventions for self-harm? Here's a discussion of DBT by Marshall Linehan's mentee. Is clozapine the drug of last resort? These would be examples of first-person questions. And in the family questions, for example, I had Dr. Bill Miller, who invented motivational interviewing, answer the question, how do I get my family to talk to someone who doesn't seem ready for help? Dr. Christine Moutier, the medical director of the American Foundation for Suicide Prevention, answer the question, my family member is expressing suicidal thoughts. How might I approach that? So the joy of this project is this is a practical book that is based on real people's stories and what they have learned. In this way, the real people I interviewed are also experts. They have a different kind of expertise than the director of the National Institute of Mental Health or a world famous researcher, but they are also experts. And that is the joy of this book. So if any of you are inclined to buy it, go right to Amazon. If you want me to do an event for your organization related to the book, send me an email, ken@nami.org. I have 130 people from 38 states, and I'm going to be traveling America beginning in September, and I'll have people from the book on the stage with me everywhere I go across the country. So 988 is a big material intervention that NAMI's doing, and the other big project happens to be this little book that I worked on. 988 is kicking in about July 16th and is going to simplify people's experience of seeking crisis services, but it does not itself create services. So I want to emphasize those are two major things that NAMI is working on. NAMI has support groups, peer support groups, educational programs in schools. It covers the entire waterfront of peer support that is all free, whether the peer is a first person lived experience or as a family member. So I want you to know about NAMI. I want you to know NAMI is a beautiful organization filled with amazing people. I only scratched the surface in terms of my interviews. So Catherine, I'm going to stop my remarks there. I think I'm at 10 minutes. I'm happy to pick up questions near the end of today's session, and thank you for having me.
Thank you, Dr. Duckworth, for your leadership and for sharing a little bit about this book, and we look forward to having you on for the Q&A. Next, we will hear from Dr. Chyrell Bellamy, an associate professor in the Department of Psychiatry. She is the director of Yale's Program for Recovery and Community Health and serves as a senior policy advisor to the Connecticut Department of Mental Health and Addictions. Dr. Bellamy has experience as a frontline service provider, a community educator and organizer, and as a community and academic researcher. We are grateful Dr. Bellamy is with us today to share more about peer support and culturally responsive approaches to mental health care. Dr. Bellamy?
Thank you so much, Catherine, for that introduction. It's a tough act to follow after Dr. Duckworth. Very excited to hear about the book that you did for NAMI, and particularly that you're honoring lived expertise. So I'm happy to get, I'll be happy to get a copy of it in my hands. Thank you for the work that NAMI does nationally. So if we can get started with the presentation. Next slide, please. So let's just get started. Here's a poem that was written by my friend and colleague, Imani Harrington. Imani Harrington is a playwright, an artist, poet that lives in San Francisco. And we wrote a book together called Positive Negative Women of Color in HIV and AIDS. We need you, our brothers, our sisters, and our people. Help us reaffirm ourselves in loving ourselves. Hold us when we can't stand, because soles of shoes have traveled on our backs for so long. We need you, our brothers, our sisters, and our people. Thank you. Next slide, please. Keep going. So, unfortunately, the situation that we're dealing with right now is pretty dire. We know that Black and Latinx people and people with mental illness are dying 25 years earlier than the rest of society. And there's a lot that we need to do to change that. Next slide, please. For Black and Latinx communities, we are still needing to address things like stigma and discrimination with mental illness. Again, as Dr. Duckworth mentioned, COVID has unified us in a sense, right? So that people struggle. We know that people have struggled. We know that, COVID has really brought to light what mental health means. But we also know that for many people that have major challenges with their mental health, the stigma and discrimination continues to be something that's very real. We need more positive messages. We need more people that are out like me, as well as others that are out about their own mental health experiences across the board. We also need to make sure that we are doing our best to improve healthcare improvements for all, and particularly for Blacks and Latinx. We need to find ways to enhance the issue around trust in the healthcare system that sort of plagues our communities. One way is by bringing in and supporting more providers with diverse racial and ethnic backgrounds, and developing more clinical staff trained in providing culturally responsive care to our communities. And then we need to make sure that when people are seeking mental health services, that they have access to it, and particularly folks with private or no insurance. Next slide. So introducing peer support. In an ideal world, we could all provide peer support based on our life experiences. We do it every day, different issues, but similar results. I know for me, as a person I was in my 40s, having my first child, I needed peer support from other moms about what is it like to be a new mom, and particularly what is it like to be a mom who's older. I also would have benefited from peer support when I was 16 and suicidal, and throughout my years of going to college when I was dealing with some major challenges related to my mental health experiences. Peer support has been defined by the fact that people who have life experiences can better relate and can consequently offer more authentic empathy and validation. People with lived experience can offer each other practical advice and suggestions for strategies that professionals may not offer or even know about. Next slide, please. So what are some of the gifts peer supporters can offer? And I say gifts because I think that lived expertise is a gift. The installation of hope, that hope is possible, particularly that's so important right now for many of the people who are dealing with effects of long-term COVID, et cetera. Modeling one example of recovery, you know, there are so many different ways and so many pathways to recovery, but having a model of what it could be and what it looks like is very helpful. Mentoring, coaching, engagement, and connection. The art of connection is huge. Some people just need having someone there that they can connect to about their mental health experiences, but also just about, you know, what is it like to live life on life terms, right? So, and then there's street smarts and navigating the system, navigating the mental health system, that is, for people who have never been through the mental health experience, knowing how to connect with it, how to access care, what's going to happen as they're going through the system is going to be really important. Community networking, and again, community connection is also key. And I also have here Lift as We Climb, which is a term, a phrase that was coined by the United Colored Women's League back in the early 1900s. And Lift as We Climb essentially means that as we are climbing the ladder of success, that we are able to grab a person's hand next to us so that they are climbing with us. And that's just really key to the work that we are doing in the field of peer support. Next slide, please. And, you know, here's just some initial evidence. And we've done a lot of work at Yale's Program for Recovery and Community Health under the leadership and my mentor, Dr. Davidson. So particularly, the outcomes are equivalent to non-peer support providers, with some studies showing slightly better outcomes with peer support staff. And that's earlier work by Phyllis Solomon and colleagues. Also, that longer community tenure in those receiving peer support in one randomized controlled trial. Peer support staff show ability to reach people who have more vulnerabilities or are harder to engage, and that's by my colleagues here at Yale, Michael Rowe and Dave Sells. But we know that we are only scratching the surface, and we are really encouraging NIH and other funders to support more research, because more research is needed to examine the effectiveness of peer support, not only in mental health, but across a variety of different fields, because we do know that it works, and particularly to examine the culturally responsive approach to it. Next slide. So introducing the Imani Breakthrough Faith-Based Recovery Program, and this is a project that's currently being funded by NIH via a U01, but also we do programming through Connecticut's DMIS and SAMHSA through the state opioid recovery response. So we aim to promote healing, health and healing for ourselves and our communities. How we do this by creating a sense of unity, that we are in this together, creating a sense of collective responsibility through a participatory process. And key to the work that, you know, we do in community, but that all of us should be doing in community, really involves participation by those with lived experience, by family members, as well as by, you know, neighbors, policymakers, leaders, etc. Next slide, please. This is just a photo of some of my colleagues. There's my co-PI, Ayana Dr. Yana Jordan, who's at NIU, and these are just some of the pastors who are involved in the Imani Breakthrough Initiative. Next slide, please. And these are actually some of our facilitators, our Black and Latinx facilitators who we train to deliver the Imani Breakthrough. Imani takes place in 4 churches. That's 4 Latinx churches and 4 Black churches in the state of Connecticut. And we're really providing, while Imani was developed initially to help people who have issues related to opioid use and particularly addiction in general, we know that mental health is a huge issue for people who are using addiction. And so now is the time to make sure that we are not separating these issues, that we are impacting mental health as we are addressing issues related to addiction. Next slide, please. And this is just a quick overview of Imani, and you can feel free to reach out to me, but it's a 6-month process, which includes a 12 weeks of classes and activities focused on the 8 dimensions of wellness, developed by a lived experience researcher named Dr. Peggy Swarbrick, who's amazing, as well as Dr. Michael Rowe, in the 5 R's of citizenship. So we combine those 2 and we train people around those areas, as well as provide sort of wraparound peer support as well as community support. Every Imani project is facilitated by a person with lived experience, as well as a faith-based member of that church. Next slide, please. And so these are just some of the unique factors of Imani. One is that, you know, we definitely have to make sure that we are doing the naloxone distribution. Is so important that we are able to save lives, and we have to do more of that. People are dying because of the opioid epidemic, and we really need to do better at reaching people. It addresses harm reduction, and harm reduction is really key to making sure that people have, particularly people who are continuing to use, that they have the supports that they need. Intensive wraparound coaching that is built on primarily issues around spirituality. And spirituality, as we know, is huge culturally, but I can bet that, you know, many of your mamas and grandmamas are probably praying for you right now. Next slide, please. And this is just some demographic information about, you know, some preliminary work from Imani. As you can see in this end of 1008, that the folks that we are really reaching are people who have some huge vulnerability. 74% have experienced homelessness, 65% experience violence as an adult. Many have experienced issues with childhood, you know, physical, verbal, sexual abuse. As you can see, while the project does target Latinx and African Americans, we also serve white folks as well. The project is open to anyone who walks through those doors. Next slide, please. And Imani has showed some significant changes. So we know from baseline to week 12 that there were changes for people who came in with using substances, that at the end of 12 weeks, we saw changes in overall wellness across all of the 8 dimensions. And this was huge. And this is a huge reason why we need to continue to focus on the 8 dimensions, because it's not just about issues related to addiction and mental health for people. It's about being able to address all those different aspects of people's lives. Next slide, please. And the next slide relates to our citizenship measure, again, developed by Dr. Michael Rowe, and that's really across those 7 domains of citizenship, such as stewardship, civil rights, caring for others, personal responsibility. And again, you can see that there were increases over time from baseline to 12 weeks. Next slide. So what can we do, and what can we do today? And I'm going to start from the bottom. So the first thing is that, you know, even though COVID may have made the playing field, so that we're all sort of impacted. We do need to do more to stop the discrimination associated with mental illness and addictions. We need to fund peer support research and programs. We need to expand these programs, particularly peer support, to communities of color and really focus on culturally responsive care. And we need to provide insurance coverage for peer supports and community health work. I think that's very key to the work that we're doing, but we do need more coverage and funding in that area. So thank you so much, and I appreciate being here with you all today.
Thank you, Dr. Bellamy, for highlighting these great examples of peer and community support and for some guidelines on what can be done today. Next, we will hear from Dr. William Beecroft, Behavioral Health Medical Director at Blue Cross Blue Shield of Michigan. He has been instrumental in the development of innovative programming in behavioral health, including collaborative care, crisis programming, provider-delivered care management, and first episode psychosis programming. We're grateful to have Dr. Beecroft here today to share Blue Cross and Blue Shield of Michigan's efforts to support mental health and crisis services. Dr. Beecroft?
It's been an honor to be on this distinguished faculty panel today. It's an honor for your time to listen to our story of being able to help individuals in our community be able to access care. It's been an honor in my career to be able to take care of a lot of people with behavioral health conditions over 38 years in practice. And then here at Blue Cross Blue Shield of Michigan, it's been an honor to really help develop, along with the team and along with the company, these services to be able to improve access and be able to help people. And all those things that they said I did, I didn't create those all myself. It's been a whole team that's been doing this, and we only took the literature and its evidence-based as an evidence to go forward. But with crisis services, we'll dive right in here. It's the right care, the right time, the right place. SAMHSA, I think, has put it together very, very well in their roadmap to crisis services. Next slide, please. And what we're really looking at doing is trying to be able to do things that the public system has been doing for 20 years or more very, very well. You can move on to the next slide, the executive summary slide. In many respects, they have gotten it right to be able to get urgent and crisis-based interventions done quickly. Emergency rooms are very good to be able to take care of people that need services, but for behavioral health services, they can be life-saving, but also they can be very difficult to work within. I did an awful lot of that in 38 years. And being able to have confidentiality, being able to have a quiet space, being able to have a safe space, because in anyone that's gone into an emergency room, there's all kinds of wires and things you can hang yourself on and hurt yourself by cutting. There's all kinds of things that can get you in crisis. So being able to look at crisis services, I think, is really something that we can develop an alternative path to getting those services that are really required for those individuals met. Psychiatric urgent care is taking on kind of a life of its own, but this is for, just like urgent care for medical services, a place that people can go, be able to get assessed fairly quickly. If they need higher levels of care, that can be helped. But usually it's things like being able to get, a prescription refilled, or being able to find out if they have something that needs to have higher level of care, can they get an outpatient therapy appointment and kind of work in that direction. Where we've really picked up the task is developing a system of payment for mobile crisis services and crisis stabilization. You can go on to the next slide. We also have crisis residential already paid for. The next slide shows the mobile crisis concept, and being able to have a mobile team. You can move on to the next slide. Maybe hanging up. There we go. A mobile type crisis team is a master's level provider, at least, with a peer support that can go out to a person's home. They can go to a primary care doctor's office. If the primary care doctor, we need to go back one, I'm sorry. Back on the mobile crisis slide. They can go to a primary care doctor's office who's done the screen of a PHQ-9 and ask the number 9 question, are you suicidal? And they could be able to come into that office and assess that individual, be able to look at what is the diagnosis that we're dealing with, what would be a nascent treatment plan to be able to put together, be able to coordinate that with the individual and or their families. We have this also available for children. And be able to put together a plan that they might be able to get a psychiatric appointment quickly within maybe later that afternoon or the next morning, get them involved in a partial hospital program, or take them to a crisis stabilization unit, which we'll talk about in a minute. They could also go into an emergency room to be able to help provide those services that many emergency rooms don't have, especially don't have quickly. And in our plan, the providers that we have can either reach out by telemedicine or they can reach out in person within minutes to hours, not hours to days, like sometimes happens in emergency rooms. I'm not beating up on emergency rooms. They're extremely important in our society. But for people with behavioral health conditions, this may offer a substantial alternative level of care that can provide more focused, more directed care towards their needs. Next slide to the crisis stabilization unit. A crisis stabilization unit is actually a physical location. And this is an example of one of our providers' lobby area, kind of the setting that you'd be walking into as a citizen coming in from a community. You can also call them. They can do this by telemedicine to a certain extent. But the actual physical examinations really need to happen in a facility. And we're also looking at being able to house people overnight for the observation part of it. Crisis stabilization units are akin to a med-surg observation unit, which has been around for about 25 years. This is a place where you'd come in, you'd be triaged into a meeting with a mental health professional. At that point, they could make a thorough diagnostic evaluation, an assessment, work out a treatment plan with you of what you agree to be participating in and what your needs might be able to get a psychiatric evaluation if needed. And at that psychiatric evaluation, treatment could be initiated. Also, if you didn't need the psychiatric evaluation for medications or additional psychotherapies, the mental health professional that saw you could initiate treatment of a psychotherapy of whatever need you have, a family therapy appointment. But you're also there working with peers, and if you need additional testing, say medical testing, laboratory exam, imaging, anything like that can be done in this type of a facility or coordinated with this type of facility. So the treatment would be initiated. You could be observed for a period of time. You could overnight. And just like the med-surg observation units, the length of stay we're looking at is no more than 48 hours. That we really need to triage you into the next level of care, and that care needs to be coordinated by a warm handoff. It could be a crisis residential program where you're going to be staying a bit longer in a 24-hour-a-day supervised setting. Could be into a partial hospital where you actually are going home at night. Could be in an IOP where you're maybe going to work and come into this 3 or 4 times a week, or outpatient work. You still could go to a hospital. SAMHSA says that about 40 to 45% of people are still going to need a psychiatric hospitalization, even if they go to a crisis stab unit. But the idea here is that the other 55 to 60% don't need that level of care and can get care that they need in a less stigmatizing, a more comfortable, a more confidential space. Next slide, please. There's a couple slides here that we'll probably skip through pretty quickly because we've already gone over the distribution of services. This one goes over some of the things that you've already seen, so we can move on to the next slide. I think in an effort to preserve time, I will skip over some of these pretty quickly, but this one is really important because now I'm moving into talking about another alternative way of being able to improve access. We know that about 80%, arguable between 75 and 80%, 85% of primary care doctors Prescriptions for antidepressant medications are made by primary care doctors. We know that the mental health and behavioral health workforce is not enough, not adequate for our population. So the two teams really need to ally together. And that's where collaborative care can be a really significant value going forward. In 2014, Milliman did this report and looked at 14% of the patients with insurance consumed 30% of the total medical spend for their care. So this is the business case of looking at not so how expensive behavioral health is, but how important it is to treat the entire person, not just their behavioral health needs or their medical needs, but to treat them all. It's been mentioned previously that people with schizophrenia die anywhere from 25 to 28 years earlier than an age-matched population without schizophrenia. And it's really important to take care of them, as well as people with depression, all the other mental illnesses that can occur, and substance use disorder. We also know that the medical costs for treating people with chronic medical illness as well as mental health illnesses are 2 to 3 times higher than those for treating people with conditions that are just one or the other. And also the majority of projected savings is from the integrated care are associated with facility, hospital, and emergency department utilization. Integrated care is an important term because there's multiple forms of integrated care. We have chosen to move towards the collaborative care model. That doesn't mean that the other models are not effective and helpful, but the collaborative care has the most data to support it and evidence-based, and that's where we have focused our energies. Next slide, please. Collaborative care has a little different team kind of orientation, and it's population focused because we screen everybody in the primary care practices and identify people with primarily anxiety and depression, but we're also looking at pediatrics populations, substance use disorder populations, populations of people with severe mental illness. And it can be also, we're looking at developing a high-risk pregnancy perinatal program to be able to use this. It's measurement guided, PHQ-9s, GAD-7s, whatever the tool, whatever the population you're really screening for is what tool you can use. And it has substantial evidence base. There's over 90 evidence-based trials that show collaborative care to be very effective. Next slide, please. The model is a little different than a regular practice in medicine. In many respects, the medical field, the primary care field, has always been the primary provider being kind of the captain of the ship. And over time, we have developed other things. We've developed other practice strategies using team medicine. The family-centered medical home was one of the first ones, and then provider-delivered care management came along about 12, 14 years ago. And now collaborative care is another descendant of those team medicine components. But what we add is the psychiatric consultant and the behavioral health care manager that coordinate what's going on with each case that has been screened into this program. The behavioral health case manager is the primary liaison along with the primary care doctor to the patient. The psychiatric consultant never sees the patient directly in this model. They can do a consultation, but that is a rarity. Mostly it is that psychiatric consultant is reviewing the cases, being able to advise the primary care provider as to what's the next step in this person's care, be it a different type of psychotherapy, getting them into psychotherapy, being able to look at which medications might be appropriate. If the medications are ineffective or they're having side effects, how to be able to change, how to be able to add adjuvant medications to this. And when enough is enough in this setting and we really need a second tier or tertiary care intervention for that particular individual. Another big piece of this is being able to have people's data really checked with through this systematic case review tool to keep tabs on the progress, to keep tabs on the labs that are going on, the interactions with their therapists, these sorts of things. Next slide, please. So couple testimonials here, and then I'll jump on to another couple slides, and then we'll be able to have some questions. But a patient testimonial, and this is a real patient. This isn't just an actor telling you all these things. This was a family member who was enrolled in collaborative care. She enrolled for about 2.5 months, uses the tools every day, learned during her calls with the behavioral health case manager what she needed to know about the issues that she was dealing with, and looks forward to her follow-up calls. The other one is a provider testimonial. And the biggest thing from this is that the collaborative care model made a huge difference in that particular provider's ability to manage their patients' mental health in the long term. Case manager has been able to spend more time with me, has been able to provide vital information, and in helping to manage the patient's complex social and mental health outcomes. In this model, they can also deal with the social determinants of health, being able to look at the logistics of getting people where they need to be, coordinating with the other people that are touching them in the care modeling system, and families, being able to coordinate with family members. I go to a lot of regional medical directors meetings, and what I hear back is that from the primary care doctors especially, is that we're 75, 85% of us are burned out. Many times colleagues of mine from working in the hospital say, I really don't want to be a doctor anymore. I want to go be a carpenter. I want to do something else. After a year in this program, I get the feedback, hey, I love my job. I love being a doctor. My patients get better. I want to go to work every day again. So much different. And we can't afford as a society to let any doctor just leave medicine because they're burned out. We have to take care of them to be able to move forward. And I say doctors in a very generic term, any healthcare provider at any level of care. Next slide, please. So in Michigan, we've really done a very aggressive program to be able to pull together and train providers. We have been able to train up 180 practices in the last 2.5 years. We had put away some practice transformation funds that was available for us to be able to do this. And after making the case to our senior administration, and they very heartily grabbed this and said, this is a great model to move forward with, and has been very helpful in backing this program. 84 have been added in 2021. We developed a pediatric module for our training programs, and we've partnered with a large Midwestern university and also a clinical innovations program on the west side of the state. So we have a distribution of using the same curriculum that we all developed together, but an ability to train people in different parts of the state to be able to do this. The pediatrics practices asked for us to develop this module. And so we put this together, and we've trained up 20. They're really working quite well. These are practices, and practices aren't just one doc or one nurse practitioner or one clinical nurse specialist or PA. They're a bunch. So we have 600 practitioners that we've actually trained, and 800 practices. 800 should be practitioners, not practices, receiving the value-based reimbursement that we offer to get people incented to do this kind of work. We're also launching a co-care designation program to be able to then have our members and case managers be able to find these programs much more quickly than us knowing where they are. Next slide, please. I think that brings us to probably questions. Oh, our pediatrics adolescent model. This is the adolescent model. It really does look at the difference with adolescents and kids. We've driven this down to about a 10-year-old is probably the earliest age group we want to try to manage in a primary care setting with these kinds of needs. But the additional components of that practice is looking at community-based services, therapy, therapists, medical, being able to coordinate with health coaches and community health workers, peer supports, to be able to really help all that system work together. And consequently, it takes more time for the behavioral health care manager to be able to manage these cases, and their caseload can't be quite as high. But the additional members, as you see on the right there, is the parents, schools, the therapists, other community resources can be extremely helpful. And we can move to the last slide. So the key takeaways here is that crisis services can really offer specialized, specific care, being able to decrease stigma because you're going to not necessarily an ER in a very unconfidential place, but being able to have a confidential place that's not necessarily associated directly with a hospital, although they can be. They can be on the hospital campus. It's a more comfortable setting. It's safer in the greater scheme of things, and can be able to utilize the acute care hospital setting for people that are having other severe life-threatening needs, such as a heart attack, a stroke. It's not to say people with behavioral health conditions don't have those also. They do, and they need to be in that ER also. But for people that don't have those immediate needs, the crisis services really can be an additional adjunct and an alternative path. And collaborative care really increases access. In my practice, I panelized at about 600 to 800 patients. That's as many patients as I could take care of effectively. In this practice, I've talked with other people that have been doing this and other big centers. We're thinking that about a psychiatrist can be able to have psychiatric influence on the care of roughly 2,500 patients. So that multiplier of being able to work as a team with primary care and psychiatry together, being able to really work on taking care of individuals with a trusted provider that the individuals have. They have a trust of their primary care doctor, less stigmatizing. They don't know, nobody from the outside knows if you're going to get treated for a cold or for your depression. So that really prevents that issue of stigma in general. So with that, I would open it up to questions. And again, thank you for your time for listening today.
Thank you so much, Dr. Beecroft. We would like to use our remaining time to engage in our Q&A session. I'll ask our panelists to come off mute and back on video, and our audience can continue to submit questions via the Q&A tab. I'm going to start with a question for Dr. Bellamy. We had an audience question about could you describe the tool that you use to rate changes with regards to the 8 dimensions of wellness?
Hi, thank you so much for that question. The tool is pretty massive, but I can send that to you. I'm at Chyrell.Bellamy at Yale.edu, and I can certainly share with you our 8 dimensions of wellness measure. But it covers all aspects of those 8 dimensions and really engages with the participant to help them figure out, whether or not they are meeting those 8 dimensions. That tool can be used as an instrument as well as a tool that can guide someone working with the person around those 8 dimensions. But I would be more than happy to share that with you.
Great, thank you. Next question for Dr. Duckworth. You had mentioned some teen support groups, and Dr. Beecroft had talked a little bit too about their adolescent care model. Could either of you talk a little bit more about caregiver and support for parents of teens struggling with mental health issues? And specifically, does Nami have a support group that people could access?
So Nami is 650 affiliates across America, right? So everywhere you are, there's a program. There are multiple programs in Michigan. There's multiple programs near New Haven. Catherine, where are you today?
Virginia.
Nami, Northern Virginia is a powerhouse. I live in Boston. There's a comedy of Nami resources. So each individual affiliate has its own capacity. So you have family to family, which is adults typically who are parents of adult children who have serious mental health conditions. There's a program called Nami Basics, which is for parents of younger children. There are peer-to-peer programs. So I guess what I would say is start by contacting your local Nami. Find out what support programs they're up and running. In Bucks County, they run 150 programs a month, and I'm not making that up. I interviewed one of the leaders in Bucks County, Pennsylvania, north of Philadelphia. That's what he told me. It's incredible. So these programs are all free. They're all with people like you, same or similar developmental stages. Now in college, there's Nami on Campus. That is the largest program at America's favorite basketball university. I'll leave it that. It's the biggest program at the Blue Devil University. So that is something for younger people directly. There's also a place called Active Minds, which is a nonprofit, which is directly devoted to youth mental health. So I think the place to start is contact your local NAMI, see what they're offering for you.
Great, thank you for that question.
They do excellent work, and our behavioral health care managers internally have them on speed dial and the other community resources. But we've also done some specialized services in Grand Rapids to be able to help support community support groups and that sort of thing.
Great, thank you. We have several questions from audience members and comments on the shortages that we're facing that we've been discussing today. Can any of our speakers talk about what you see as some of the most promising strategies or policy changes that can help change requirements and ease access to different types of mental health practitioners?
So it takes 8 years to make a social worker and 8 weeks to generate a demand crisis, right? So the workforce is nowhere near, what we need at this point. So Dr. Beecroft's collaborative care is a way to deploy psychiatrists smarter so they can take care of thousands instead of dozens of patients. There are loan repayment models that are engaged, but I don't find them to be nearly as comprehensive enough. Technology is one potential avenue. So telehealth doesn't create people, but it may improve efficiency for people in terms of getting help. And in the book, I have John Torres, who's the king of informatics for the American Psychiatric Association, review how to think about all these many apps that are out there. There's now 20,000 apps that are out there. It's a completely unregulated space with rare exception. And so how do you think about that? Is that a supplement? Is that a replacement? Each individual story is different, but there's no question the mental health field needs more people, needs more diverse individuals. So we have to create the conditions that people want to do this work. It isn't easy. We have to pay for it so that you can have a viable career paying off your student loans, right? So I would say collaborative care is the best answer. Dr. Beecroft developed that very well. Technology apps, technology resources are a second thing to consider. And the third thing is we have to help mental health practitioners with their student loans.
I would agree with all of those things. We found some disparities in different counties in Michigan that the federal level of reimbursement for student loans is different than the local level, and that the individuals get stuck in between and they end up not getting their loans repaid. So we have to figure out that on a regular basis and coordinate that loan repayment can be for everybody. When they do the work with a nonprofit, you've got that program, multiple different programs to make it easy, to push the easy button here. We have to make it easier.
Yeah, I would agree with everything that's been said as well in terms of loan repayment initiatives, as well as telehealth approaches. And again, to continue to fund and support peer support initiatives. I also think that we should move toward, we're doing well at setting up crisis stabilization, but also adding peer respite, and peer respite that's run by people with lived expertise would be very beneficial. but offering other options for people. And in terms of access, I think, for those who are not accessing through traditional ways, I think we should also look at more street psychiatry initiatives and really doing more outreach to get people out there and where people are in the community.
Two follow-up questions to that. One, for Dr. Duckworth, you mentioned this proliferation of mental health apps and technology, and how do we help people understand that? What additional research is needed to unlock the potential for that, to help people?
Yeah, so the American Psychiatric Association has something on their website to help you evaluate a mental health app. They look at privacy, data sharing, what might it offer you. And some of these apps, unfortunately, are not attentive to things like privacy and data sharing, right? So you have to think this all through. And what Dr. Don Torres, who's the leader of the APA Informatics Committee, says basically is look at this tool and figure out what it is you think you need. Many people download apps but don't engage with them. So the key is to find something that will work for you, that you will find compelling. Downloading an app is not the same as benefiting from the use of an app. So there's plenty of companies working in this space. Very few of them are FDA approved. It's a tremendous lift to do that. But the APA's, the American Psychiatric Association Technology Center, it'll come right up if you Google it, and just evaluate, how do you think about these 20,000 apps that are out there? Because there might be one that could help you, but you should know what the limitations are. Because it is the Wild West, Catherine.
Dr. Bellamy, follow up to one of your comments. How do we meaningfully integrate people with lived experience in the co-design of policies and programs?
First of all, it's about believing that it's important, right? So, and I think that's really key that, we look at other, countries like the UK and Canada where lived experience is key to all of the different initiatives. It dictates funding for programs as well as for research. And so we need people involved in co-design efforts. And that's people living with, as well as those family members as well, at the table discussing these issues, designing the research, being a part of the analysis of the research, and also being a part of the implementation. But we got to do more than just give lip service to it. We really need to center the involvement and get people involved in doing the work of participation.
Great. We've talked a little bit today too about stigma, and are we at a tipping point of overcoming stigma? We've seen some strides coming through the pandemic. What barriers remain, and what are some effective interventions to decrease stigma, to increase access? And also, a part of that too, Dr. Duckworth mentioned the 988 crisis phone line. How can we, how can folks on the meeting today help promote that line and just continue this conversation on mental health and not lose sight of it?
So shame, prejudice, and discrimination is how I think about it. I'm not really a big fan of the term stigma. I don't think it adds anything except the potential for another barrier. And I think you've seen a transformation in attitudes towards mental health. The supply-demand mismatch is one evidence of that. Try to find a therapist now. It is really not easy. More people are seeking help than ever. That does not mean the problem is solved, and it does not mean it is happening evenly in all communities. But one of the reasons I decided to actually interview real people for the book was to expressly get to that instead of what doctors do, which is make composite fake people. I don't think that was useful. The reason to protect a person's privacy if you think there's something to be ashamed of. So I invited people who want to tell their story, to tell their actual story. They're actually real people. It's not a fake person named Tom Smith from Ann Arbor, Michigan. There's a man named Tom Smith. He lives in Ann Arbor, Michigan. He's living with bipolar disorder and he's trying to figure it out. So I think this is a little small step that Nami has tried to make. People telling their story, both in all our multiple programs and in our little book.
Thank you for that. We are out of time. We have some additional questions. If our speakers are willing to take them, we can share them with them directly for follow-up. But do want to be cognizant of the time and thank our excellent panel of speakers for being with us and sharing your work and perspectives. We will be making a recording of this event available as well as slides. Thank you to our audience for joining our discussion and for your questions. Your feedback is important to us. You can take a moment to complete a brief survey that will open on your screen after the event. A lot of great resources have been mentioned today. We also have some resources available on our website, including a recent infographic on mental health care and solutions. So thank you all again for joining us today for this important conversation.